Dr. Stephen, welcome. Thank you so much for being here.
Thanks so much for having me back, Katie. It's great to talk again.
It is so great to chat with you again as well. And as I've said on this podcast before, I love talking about oral health because I think it's so foundational to the health of the whole body. And I think there's a lot of misconceptions and misunderstandings when it comes to different aspects of oral health. We got to delve deep on some of those in our first episode, which I will link in the show notes. But in this one, I'm especially excited to talk to you about jaw development and bone structure and some other aspects we didn't get to go deep on last time because it seems like there's a lot of misinformation that goes on in this realm. And I know you have done a lot of research and work hands-on in this, and I'm excited to learn from you. I guess to start broad, I would love to talk about maybe crooked teeth in general, because I feel like that's the problem that's top of mind for a lot of parents is if their kids' teeth are crooked, their immediate thought is braces, or we need to fix the alignment of the teeth. But what should parents be aware of when it comes to crooked teeth in kids?
Yeah, kind of as an overlying message for parents out there, and one of the bigger misconceptions I think that really exists for parents, with young children, is that they can actually participate in their child's jaw growth. So they can understand how their child's teeth are developing and actually help their child to grow a jaw that fits adult teeth. Now, that's something that we probably didn't grow up with, Katie, but having kids, you have 6 kids and I've got 3 kids now. Actually, since we last spoke, I had 3 kids under 3, and so my oldest is now 4. And so I'm kind of living, the both sides of this world where I'm watching my own children grow, and we're treating these children in the clinics. And the great thing that I'm, seeing now is that as this has been going on, since I wrote my book in 2018, that parents are starting to wake up to this. And we have people coming into the clinic and asking, hey, this seems to be not right, how my kids' teeth are coming together, or there's this habit that I'm not sure that seems right. What can we do about it? So it's like an awakening in the sense that parents really should be focusing on the growth of the jaw, because it influences how a child feeds, how they sleep, how they breathe, and ultimately the base of the jaw really forms the foundations of the brain for the child and the neurological system, the neurohormone system that releases all of the endocrine hormones throughout the body. So when we're really thinking about any kind of growth and development factors for a child, we should be thinking about how their jaw is growing.
That makes so much sense. And I feel like it's the opposite of how it's often thought about, at least in the US where I am. I think we look at the teeth and just think of like rearranging the teeth versus making more room for the teeth to fit naturally without having to be kind of rearranged in such a harsh way. And I think also this concept was first introduced to me, I've read in your work as well, but from Dr. Weston A. Price years ago when I was first getting into health, I read Nutrition and Physical Degeneration, and his comparison of the jaw structure of these more different cultures compared to the modern Western world, and how drastically different it was, and how drastically it shifted in the span of just one generation when some of those factors were changed. So let's talk about some of the factors that come into play here. And I know that there are things people can do even if their kids are already older, but I'd love to talk about, in a best case scenario, how do we set this up pre-birth? How do we set this up from the ages of your kids? Like, how do we give our kids the best shot at this?
Yeah, exactly. So Weston A. Price's book, Nutrition and Physical Degeneration, was my kind of entry point into this whole world. As a dentist conventionally trained in biomedical science and then into clinical dentistry, I was taught that, crooked teeth is something that you identify. So like, this is this type of crooked jaw and this is this type of malocclusion. So class 1, class 2, class 3, and that's it. This is how you fix them. You refer them to orthodontics, or you do general practice orthodontics to correct them. Weston A. Price was a guy that went around in the 30s, and he showed that in human populations that eat the traditional diet, they do not get any of the dental diseases that we see in today's modern population. So that's tooth decay up to 30%, and up to 50% in pediatric populations have decay now. Now, he showed that both decay and crooked teeth happens in one generation when we feed our kids the modern diet. And so when the parents and when the kids have the modern diet, when we come off traditional foods, then we begin to see this collapse of the jaw, and we begin to see a rotting of the teeth. So up to 30 to 50% in tooth decay. And so for a dentist trained, in the early 2000s, this was normal to me. This is like my identification process. We look at cavities and we look at crooked teeth and we fix them, and that's it. Now, Price was talking about, hey, how do we get in and understand why this is happening? And so that's where this whole kind of melding between, oral diagnosis and functional medicine principles, where we're actually thinking about why diseases are happening, starts to really show us that, hey, the childhood jaw growth and development period should really be something that we're watching closely. And, there's a lot of evidence that popped out in the early 2000s, the Human Genome Project, that showed that, the genome, whilst we can map the amount of genes, it doesn't explain the amount of complexity in the human body. And that kind of unearthed the whole science of epigenetics, that then showed us that, hey, our environment is influencing the way genes express. And that begins to show that even before a child is born, there are epigenetic factors that are influencing how a mother will pass on, how a father will pass on his epigenome to their unborn child, and then how that relates to their growth and development in the womb. And this is what we're seeing now, is that, many kids, babies in particular, aren't born with a jaw that really gives them, a good go at latching and feeding well. And that's all the start of it. So a child's jaw starts to grow, roughly from about 12 weeks in utero. And one of the big factors that we miss is that the disconnection of the areas of the fetus that disconnect the jaw and the tongue actually happens in about 12 weeks. And so in this period, when you don't get a disconnection, you get a tethering of tissue between the tongue and the jaw, which we know as a tongue tie or a lingual frenum, which then can pin the tongue down to the floor of the mouth. And this is a reason, or one of the ways that neonatal influences can actually show how jaw growth can be affected. One, by nutrition, because we know that midline deficiencies such as tongue tie is affected by folate and B vitamins and so forth. So when we don't have the correct versions of B vitamins, it's just like we get spina bifida, and that's why we take the activated folates and so forth. But you also get the midline deficiencies in the mouth, which are potentially the lingual frenums and the clefts as well. So we have these nutritional inputs, which Price showed were related to fat soluble vitamins. The teeth and the jawbone, the immune system, all rely heavily on vitamin D. And we know now that through pregnancy that we have almost at epidemic proportions that we have vitamin D deficiency. And we know that early childhood caries is related to vitamin D deficiency. So a vitamin D deficient mother will have a higher proportion of children with early childhood caries, which is the black marks or the brown marks along the gum line, which is really tragic for a young family, because it's such a hard thing to go through. But we're starting to see now that these deficiencies are playing a role into how a child then develops, and the eruption of the teeth is the same. So, in the first 6 to 12 months, a child starts to get their first teeth erupting. And in those times, what's happening is that the child's beginning to learn to chew, converting from breastfeeding to solid maybe, or maybe they are a bottle feeder, or maybe they have a habit, like a thumb sucking habit or a pacifier that stays through to over 12 months. All those things start to add on to how the teeth and jaw are developing. And the principles of jaw development lie within the physical factors, which is nasal breathing, which expands the upper jaw, the palate, and also the tongue posture, so the tongue to the roof of the mouth. Because when a child is born, their palate is soft and malleable. And so when the tongue seals upward and backwards, back to the soft palate, which is the motion that breastfeeding should teach a child, then what happens is that the palate expands and the jaw expands to fit the teeth. Now, when you get these functional issues, the child begins to learn and begins to survive in a way that it basically is taught to do, because it's got a little jaw, it's got an underdeveloped palate, which we'll talk about. But then it starts to create functional habits that then begin to form potentially a jaw that doesn't fit teeth. So we begin to get these issues that start to stack onto each other right from when teeth begin to erupt. And so this continues right through to when the child, has their full eruption of their pediatric teeth, which is, roughly about 3 years of age. And then between 3 to 6, you have you start to get the transition of the adult teeth to come through. And this is when we really start to see, hey, this child doesn't have enough space for their adult teeth. And so in all of these stages, there are intervening factors that parents can be both identifying and then starting to get their child, piece by piece, to remove the risk factors that slow down the jaw growth. So it's a really detailed, but also a really kind of, interactional way that parents can kind of take on their own child's growth and development.
I know that that's in and of itself enough information to fill books, but can you give us some kind of overview of by different age, some things parents can be aware of and start to look out for? And then we can also talk about solutions by age.
Yeah, sure. Absolutely. It's really something that's not really taught to parents, especially, is when teeth are up for a start, right? And so, as we said, so the first teeth, the lower anterior incisors begin to erupt roughly between 3 to 6 months. Kids are different. And then so you start to get these, the lower teeth beginning to cut. And then roughly between 12 to 18 months, you have 4 upper incisors and 2 to 4 lower incisors. So you got the front teeth starting to erupt, and then you'll begin to get the first molar. So once that first molar erupts around 12 months or so, what happens is the child begins to start to chew on the back teeth. So they begin to the ability to be able to crush food. And so when we introduce solids, which is at 6 months, that's when a child needs to start to create that proprioceptive message through the jaw and the brain to begin to tell the teeth and the jaw to, hey, you need to crush and grow food. It's just like going to the gym, exercising a joint, is that the jawbone needs to strengthen and the teeth need to send those messages to the brain to tell the jaw to grow. So as a child begins to, say that they are bottle or breastfeeding, as they begin to, I call it weaning, because it's a slow weaning process. But as you begin to introduce solids to a child, it should start to give this proprioceptive feedback. So, we started with a puree form, or eggs and breast milk. Basically introduction with, lunchtimes with like kefir and like a soft avocado, but then a pureed meat. But as they're going through, as they're getting used, as their guts are getting used to this baby-led weaning process, then what we should be doing is to start to increase the toughness of the food. So to start to give them the raw carrots or the bones to chew on, once they start to get those teeth at 1, so that they're developing this chewing, this feedback, because otherwise they won't learn to chew and swallow properly as they need to. And roughly by about 2, they should be quite competent in chewing and swallowing. We see a lot of kids with early feeding issues, and these are the first signs that they haven't quite developed that strength and that often it's the confidence to swallow with something a little bit more solid at the back of the throat. A lot of parents battle with that. So earlier on, 6 to 12 months, that's where we should be introducing. Now, as we get a little bit older, but beyond 2 years, between 2 to 3, we start to see, the canines erupt, and they'll have, the first molar, and then roughly around 3, they'll start to get their second molar, and that's when the pediatric face is set, because when the second molar sets in, it's the height of the upper and lower jaw that's set. They've got a lot more chewing capacity. So at these ages, between roughly 12 months to roughly around 36 months or so, a child becomes like a little human, and when they've got this dentition, they really should be removing a lot of the habits that were potentially around in the first maybe 6 to 12 months, the pacifier habits, the sucking habits, the chewing habits, because it affects the connection and the messages between these upper and lower teeth. So pacifiers and sucking habits at roughly these ages can interfere. So for instance, if you've seen a child that bites their front teeth together and they don't meet and the tongue comes forward, that's called an anterior open bite. And that's when often you get a thumb sucking habit through the night, because the teeth don't meet, because the thumb is occupying that area between the teeth there, and the teeth just splay forward. And then the child will bite, and then the teeth will splay forward and not meet. And so that's one of the first signs that the upper and lower jaw aren't meeting in the relationship that they really need to be. And so habits like thumb sucking or pacifiers will affect this. So between 6 months to roughly 3 years, we should be trying to remove that, trying to get the child independent on solids, which is a big ask in itself, because we know some kids are very picky eaters, but it really should be on parents' minds that, hey, this is the periods that my child needs to be learning this. And if there's an issue, that's when professional help, can come in. Can we identify a bite, for instance, that is not helping a child chew, and can we do something to correct? So till about 3 to 4, we have this pediatric growth period where the upper and lower jaw is set. You have this, often you don't see crooked teeth in these age groups, but sometimes you do. And so this is where a parent can start to identify, hey, has my child's jaw relationship formed the way that it needs to in order to start, allowing adult teeth to come in. And that's where really a child's teeth today, well, today we don't see it so much, but traditionally you see in these age groups, you have gaps between the teeth, and this is called primate spacing. And so, it's roughly a 1 to 2 mil gap between the kids' teeth. And the reason is the kids' teeth is nearly a third of the size of adult teeth. And what happens is that when the adult teeth erupt, there's not enough space. So if you see that all your kids' teeth are tightly fit together, it looks great in a smile, looks great in photos, but there's likely going to be a space issue when the child becomes 5 and 6, when the teeth start to fall out. And then what often we see is that the lower incisors fall out, and then you see these big adult incisors popping through without enough space, and they'll sometimes be crooked. They'll sometimes be, sometimes a little bit tipped to the cheek or tipped to the tongue, and sometimes you'll see that the teeth won't actually fall out at all. You'll actually see the adult tooth erupt behind the kid's tooth. And that's called ectopic eruption. And that's where the adult tooth hasn't been able to push the child's tooth out correctly. And it's erupted in a way that that is, unideal because, it doesn't have enough space. So you start to see these ectopic eruptions, or you see misaligned adult teeth. That's a warning sign that there's a space issue. And that's one of the prime areas where we can start to intervene and to start to identify, hey, can we get this child's jaw to grow?
And it sounds like that early feeding and mouth posture and tongue posture are very important to the degree that we can nurture that in babies, which of course are a little bit difficult to get to do what you want sometimes. But what can parents do if they're starting to already see these, like if intervention is going to be necessary? I know when I was that age, it was braces were the option, and I had the gamut of braces and headgear and that whole thing that I definitely would not wish on my kids. So what are some of the intervention options now that adjust the jaw and not just the teeth?
Yeah, that's right. So with a baby, for instance, so as you said, tongue posture is very important. So we've got an 18-month-old now, and actually she's got a sucking habit that we're trying to get her. I was just battling her this morning with her nighttime comforter. She's hell bent on having it in her mouth. And our second daughter, actually, she had that habit and she relieved it herself. It was no issue, but this daughter seems to be a little bit more kind of stubborn to keep it. Removing those habits are really important. But so allowing the child to be aware of tongue posture is a really important start. And this is a realm called orofacial myofunctional therapy, where we begin to teach the child the connection between the tongue and the palate. And the feeding history is important in that. So if they're breast or bottle fed, how the child has learned to interface that early feeding era. So breastfeeding should teach the child to seal the tongue to the roof of the mouth. But the reality is, a lot of kids, when you go back into the history, is that they weren't the best breastfeeders, or there were issues, sometimes there were noises, or they were compensatory in the way they were extracting milk from the breast. And I see a lot of kids that still do breastfeed with these tongue posture issues and narrow upper palates. So if we look at a child, say between 18 months to 4 years, the things that parents can be looking out for is, what's a child doing when they're watching TV? So what's their lip posture doing? Do they see the child's mouth opening? Can you hear them breathing when they're watching television or concentrating on something? What are they doing when they're sleeping? So is the mouth flailing open when they sleep? Is there loud, noisy breathing? Are they snoring? Are they restless? So a lot of the symptoms of bad breathing and poor oral posture show up quite obviously during sleep. And this is when a child is beginning to, as they're going into the deep sleep periods, their mouth is relaxing and the tongue should say sealed to the roof of the mouth. But if it doesn't, the child will breathe through the mouth. And what happens is you can get snoring, you can get teeth grinding. And so if a parent is picking these things up early on, so if a child mouth breathes at night, if they're waking up with a dry mouth, if they don't sleep well, the kids that don't sleep well often have an underlying sleep breathing issue. It's often due to an oral posture problem that has kind of flowed them into mouth breathing at night, and then it can become snoring. It can become sleep apnea, which pediatric sleep apnea is a very big issue now. That's when we know that the child needs to be seen by a professional, because we can teach, the parent can go through the processes of trying to teach the child to breathe through the nose, but there are often barriers between these age groups that are hard to treat. And so they are, for instance, adenoids and tonsils. So swollen adenoids and tonsils will stop a child breathing through the nose, or it will make it very difficult for a child during sleep to breathe through the nose. That's where an airway focused dentist or GP or ear, nose and throat specialist can really help to potentially identify, is there a blockage that can be removed to help the child breathe through the nose through the night, because this will really help them during the development period. So those kind of interventions are important. In general, I find I've learned that cleaning the child's nose in early periods is probably far more important than cleaning their teeth. So from day naught, getting a warm washer and washing out the child's nose and using the nose clearing suction devices early on. Whenever a child is congested, parents should be right on top of getting that cleared as soon as possible, because in a couple of days, if you watch a child when they have a cold, in a couple of days of blockages, and when they're breathing through the mouth, they will begin to form that habit. And that's how a child becomes a mouth breather, is that they have a blockage event. And then what happens is they never retrain that. And then so if a mother doesn't, or a father, if we don't retrain the child, then they don't learn to breathe through the nose again. So clearing that. So we've used, essential oils during sleep, and clearing the nose as best as we can while a child is sick to help them get through that period, alongside with all the immune support. It helps them get through that period and then breathe through the nose more efficiently after a couple of days, instead of taking on that mouth breathing habit. So in those early periods up until about 5, it really is, the diligence to teach a child to seal the tongue to the roof of the mouth, and that's tongue clicks. So face to face with the baby, so showing tongue seal, which is they're trained to watch that, and they will make those noises, but you teach them to click the tongue, and that's orofacial myology right there. If they seal the tongue up, that's what we want them to do, and that's what will help them to grow that palate. And then and making sure that they can breathe through the nose as much as possible. During feeding, it's really important that they sit up straight and chew with the lips closed where possible, because if their lips are closed, they're breathing through the nose and they're swallowing. All of that is happening in synchrony, instead of the kids are loud eaters and they're kind of like noisy breathing while they're trying to eat. That's a sign they can't breathe through the nose very well. So early on, those habits can start to tip them out, and if we can't get them to do that, then it really does, suggest that they might need an examination in that area. One other area is slow speech or sound issues. So if the child has an open bite or a high palate, for instance, which is really, very common in kids today, it's difficult to make certain sounds, S's and T's and so forth. If a child is a bit delayed or they're struggling with certain sounds, it might be a sign that they have an orofacial myology issue that they need to potentially be corrected during these early phases.
That makes so much sense. And I feel like mouth breathing is something that has been talked about more in adults lately. It seems like we're starting to become aware that there are problems with mouth breathing. I know a lot of people are into mouth taping now. So I guess kind of two-part question is, first, what if for adults who are listening, they're resonating with some of these symptoms and thinking, oh, my jaw is probably not properly formed. Is all hope lost now that I'm an adult, or are there still things that can help? And or as a kind of peripheral question to that, what do you think of mouth taping to encourage nasal breathing at night?
Yeah, so I mean, like, just a straight up answer to that question is I love mouth taping for for sleep. That's something that in my own journey, that's something that I do every night now, because it completely changes your sleep when you divert from nasal to mouth breathing. And then the reality of the situation is that we often see parents bringing in kids where they're like, hey, my kids not sleeping well, or they've got these jaw and teeth development issues, or they're not speaking well. But then we go through all the risks, and then all of a sudden they say, hey, this was me when I was young and I had braces, and then this is obviously not correct. And then we find that there is a underlying, sometimes severe or sometimes a little bit silent sleep disorder happening in the adult. And it is very common. There's currently 1 billion people on the planet with sleep apnea. That's the most severe end of that spectrum. Now, upper airway resistance syndrome is the less severe, the less diagnosed form of that sleep disorder. And that's where we have this active sympathetic drive during sleep. So the jaw, one of the biggest symptoms is teeth grinding. So adults that grind their teeth. And, parents out there, we know we don't sleep very well. So if you don't have great sleep already, and then you're reducing your sleep through the challenge of, raising infants, then you're going to have a very, very hard time regulating your own energy and sleep moving forward. And that's something we see so often in the clinic, is that parents that are just wrecked with sleep because they've been dealing with their own children's issues, and then these underlying problems in themselves have become an issue, because it's usually between the ages of, say, maybe 35 to 45 that they start to become more obvious. Between 20 and 30, 35, you don't really notice a snoring and sleep disorder, but it starts to build up, as your life becomes a bit more serious, in your 30s and 40s and so forth, as you work harder, you have kids and so forth. The energy that you have to, exude in these other areas, it really shows that your sleep is not as optimal as it needs to be. So mouth taping is a great way to do that. Now, a lot of people can't, mouth tape themselves. So that's a sign that you cannot tolerate nasal breathing. And there's two ways to go about this. One is to train yourself physically through soft tissue posture, which is the tongue and closed lip posture, to tolerate nasal breathing. And that's one muscular route. The other route is the biochemical route, which is slowing down your breath and learning to use the respiratory muscles deeply. So the diaphragm, learning diaphragmatic breathing, which might be yoga, might be Buteyko breathing, might be breath work or breath training, that helps you to understand how to use the breathing muscles, because you have to breathe correctly in the daytime in order to breathe correctly at nighttime. So if there's a breathing issue at night, there is always a breathing issue in the day. And so it means that you have to spend some time to reprogram your breathing. And so you can do this by soft muscle training. So tongue posture, doing yogic postures where you're doing breath exercise and deepening the breath and so forth. But if you still can't do that, you still can't sleep with a tape on, that's where you may need to have some kind of architectural or certain nasopharyngeal issue looked at. And so that's either a dental examination where we can look at the width of your palate, or we can look at your bite. Is there a crossbite? Is there is your orthodontic alignment blocking your airway? You can get a cone beam 3D scan that shows actually the volume of your airway, at the back of the throat, at the back of the nose. An ENT assessment, many people have deviated septums. If you didn't develop correctly orthodontically, you almost certainly have a deviated septum in the nose. And so that's something that I did last year. I had my right side corrected because it was blocked from a sporting injury, and it's helped my breathing significantly. But most parents just don't know that that's a thing. So if you can't tolerate these things, it's a sign that perhaps you need to see a surgeon, or you need to see an airway focused dentist to begin to look at, can we change the structure? And yes, we can expand adults, or we can do surgical interventions in adults, or they can do myofunctional orthodontics, which is training the jaw and breathing system to breathe through the nose at night. It's just a lot harder. And so it's a bit of a harder road for adults, and the results are a bit more subtle, but the investment into better sleep is by far worth it. And so if any adults out there are having these symptoms, I would highly recommend them looking into at least doing the training themselves to see if it's a problem for them.
Yeah, absolutely. When you think about, we spend roughly a third of our life sleeping. It seems like anything we do that improves sleep and that doesn't take effort once it's done is going to have payoff in every area of life. But it definitely sounds as well like the earlier the better with all of these, which is why with your work, it's so important for parents to have this knowledge, the younger the better with their kids, and be able to watch for these things in babies. What about as kids start hitting the age where they would typically be recommended braces? Can braces actually be helpful in this, or are there better alternatives that could be more jaw focused? Or what do you recommend with kids who come in with already some misalignment of their teeth?
Yes. So we kind of mentioned up to 6 or 7. So between 7 and 12, you have this really big growth phase. That's when all the kids' teeth are falling out, and you have all the adult teeth plummeting into the mouth. And at 12, you have the adult canines finalizing the jaw arch, and that's where you start to see the kids with the canines that maybe stick out here, or they're misaligned, or you have misaligned front teeth, or the bite that sits a long way back, the buck tooth child, or you have the recessive upper jaw where the upper jaw sits forward. And these are the diagnoses that orthodontists look at and say, hey, you need these braces to fix these issues. Now, the idea of myofunctional orthodontics is to address the cause and the muscle factors and the breathing factors that cause the orthodontic problem in the first place. And so braces can change the alignment of the teeth, but it may not affect the underlying issue that caused them in the first place. And this is where sometimes children or parents will be suggested to have extractions and then braces. And so in up to 95% of cases, I would say we should not be extracting adult teeth to align the orthodontic arch. We should be looking at growing the jaw. So once you get to 11 and 12, this all begins to slow down. So between 7 and 12, the child is extremely malleable. Myofunctional orthodontics is absolutely remarkable. We have an amazing amount of cases where you see the palate just go from this tiny, 30 mil intermolar width to up to 40, 45 mil in barely, 2 years. And then you see the huge change in this kid's face. Now at 11 and 12, we can still do this treatment. We can still expand the adolescent jaw. If there is a particularly difficult, orthodontic issue like an impacted tooth, or a tooth that is misaligned significantly, where there's roughly more than 3 to 4 mil of space needed, it's likely that myofunctional ortho won't correct that, but it will severely lessen the amount of alignment needed potentially later with Invisalign or braces. So the idea that we put braces and Invisalign on is great. It's the most effective way to align teeth. But if we do it without treating the underlying causes, then we're potentially pushing ourselves into issues. And there's a lot of people out there with orthodontic regression now, where you have misalignment of teeth after you have orthodontics. And then the other thing that people don't talk about is the jaw issues and the sleep issues and the craniofacial pain, the headaches and migraine issues that do flow on in people with history of orthodontic problems. And so even if a child is 11 or 12, there is value, in my opinion, to be correcting these issues and widening as much as we can. And, a child at 11, 12 can still significantly widen their palate. We can do things like palatal expanders and even implant retain expanders that can get up to 8 mil in an adolescent that grows. They still grow quickly, but not as quickly as the 7 to 12 age. So I would say that, identifying the problems and finding a practitioner that deals in this way is going to give the child a more lifelong result, rather than just, aligning the teeth in that sense.
That makes sense. And you mentioned so many of the sleep connections here. And I know from reading some of your stuff before, there's also seems to be a food connection. We talked about the in utero food connection for the mom and early development with nutrient deficiencies, but is there also a connection between poor sleepers at other ages and what they're eating?
Yeah, I think this is one of the big areas that, the parents aren't, really being told, is that, kids that don't sleep well, they are going through the whole, neurohormonal endocrine issue of not releasing melatonin in the brain themselves. And, we're talking here about a physical issue where the autonomic nervous system is controlled by breathing. So when a child's a bad breather, they're not going to sleep well, because the autonomic nervous system doesn't get into parasympathetic rest and digest easily. But the other factor to that is, how are we feeding the system? What are the factors that allow a child to release melatonin efficiently? And I've found that, a lot of the foods, the modern foods that we know that cause tooth decay, crooked teeth, and so forth, also, relate to how a child sleeps as well. So vitamin D, we know, is very, very important for sleep. Now, we know that in sleep apnea, for instance, we see a high connection between vitamin D deficiency and sleep apnea. So when a child isn't breathing well, they are bottoming out their vitamin D. And so there are hundreds of receptors on the brainstem for vitamin D. And so that is basically, produced when a child is, out in the sun or eating a high fat, animal based meal that is rich in fat soluble vitamins. And then the brain uses to help convert serotonin, which is the daytime neurohormone, to melatonin, which is the nighttime neurotransmitter that governs everything during sleep. So when we're vitamin D deficient, and when kids are vitamin D deficient, they are going to be at risk of sleep issues, and they're going to be, they're not going to as efficiently release these neurohormones as they need. The other big factor is blood sugars. And so when we are, feeding kids high carbohydrate, sugar laden foods early on in life, and when they're going through insulin roller coasters and blood sugar roller coasters, their sleep is going to be severely disrupted, because we know the connection between, insulin-like growth factor and, all of these connections between, one, testosterone, which is growing, one of the big growth factors during sleep, and then how our body is regulating all these neurohormones so that the child can enter into all of the 5 stages of sleep. So sugar and lack of vitamin D, I think, the 2 big parts of the modern diet, especially in children, because, when we feed kids these, high sugar, low fat foods, grains, sugars, vegetable oils, it pushes them into a state that does not yield good sleep. And so right from day dot, we, for instance, I don't think all parents need to necessarily do this, but we didn't give our kids fruit. And the reason being is that I was concerned with the amount of, fructose that a child can get from, a modern day apple or banana and so forth, but more so the way they develop this palate for sweet things. I wanted them to be, to recognize the nutritious taste of things like eggs and animal foods and so forth, and not crave that sweet food that that you get with fruit. So they didn't have any fruits, grains, or added sugars or anything like that, and they all sleep very well. I'm not saying this is absolutely what every parent has to do, but in my view, the kids that don't sleep well, we always find the diet history and the diet patterns where there's a lot of carbohydrates, a lot of cravings. We know that bad sleep forms cravings with kids that want these high carbohydrate foods. And I think that connection, whilst it can be hard for some kids to come down off those foods, will help them sleep better. And for parents to understand there is a connection between what my child eats and how they sleep and the quality of their sleep as well.
Yeah, it makes sense that it's all so interconnected, and it would seem like, as such, like approaching any of these factors is going to help in the other areas as well. So like improving their nutrition will help their sleep, will help their jaw. Improving their jaw and their mouth breathing will help their nutrition, because they will hopefully crave healthier foods, etc. But I love that you present this as like a very holistic approach, and it's so helpful, I think, to hear the different by milestones and by age what to look for. And I'm even making mental notes for my own kids as they get older, and also to know like not all braces are bad all the time, but that's not necessarily the best starting point. And it's also very much hopeful to know, even for adults, if we're already seeing these patterns in adults, and even if we're all, quote, full grown, there are still things that can be helpful. I think the conversation around sleep and mouth breathing is a really, really important one. As you said, I didn't realize it was that high, 1 billion people in the world with sleep apnea, but it seems like this is something drastically on the rise, as all of these things are. It's like we're seeing an increase, and you must see this in practice every day, an increase in all of these issues kind of across the board.
Absolutely. As I said at the start, in our practice, because we've been focusing on this for a while, we're beginning to see the parents are beginning to switch on to the fact that, hey, something's not quite right with how my child is growing, developing, and there's something there in their mouth that isn't quite right. And it's great that I've had parents that have come and fully diagnosed their kid, they're open bite, their narrow palate, they've done the whole thing because they've done their own research, basically, which is really kind of nice to know. And then basically treatment is so much easier then, because we've done 50% of the work. But the real kind of message there is that there is this huge problem in our child's life where we as a population now do not grow jaws that is adequate to fit our airway and sleep. And so what happens is that we have these kids that are really battling on a number of fronts. It's sleep, it's nutrition, it's the postural factors of mouth breathing. You see a lot of kids now on devices with their head tipped forward and they're breathing through the mouth. That does not develop their jaw the way it needs to happen, and they suffer in many different ways. ADHD medicines and so forth. All these issues that kids are suffering with, adenoids and tonsil issues, which is an underlying respiratory and breathing issue, immune problem. So they're all related to a poorly or slowly growing craniofacial system, which is no one's fault, by the way. I've also had parents that they've been onto this, nearly from day naught. They've been, eating nutritious, traditional based, animal based diets, and they still have these kids sometimes with dental decay, and they're just like pulling their hair out. And the way I kind of say it to them too is that we have to remember we're in a generational problem now. Often with kids' teeth, it will become a thing of the past, and all that work that parent did is going to, it will be fixed when the adult teeth. You're going to have a beautiful adult dentition in that child, but there is still things working through, and they're a little bit dejected in that sense. But I think we have to see this as a much bigger problem, that all parents should be kind of seeing their kid in a much bigger picture, that, hey, this is something that we're trying to fix for their grandchildren, and like the investment we do in their sleep and breathing. And the other thing too is teaching the children. I love hearing kids talk these things back to us and tell us about tongue posture and, eating, nutritious, fat-filled foods, and the way they're improving their sleep and wearing their myofunctional ortho guards, and how their face is changing. That's a child that's going to teach that to their child, and then they will teach it to their child. So I'm hoping that this becomes something that we can really embed into a societal conversation, instead of just maybe fixing child by child.
I love that. I've said that in relation to lots of areas of raising children, is that they understand so much so early, and you're in the very early phases of seeing that every day, how much they learn and understand. And I think when we put in the work to educate them, whether it be about nutrition, whether it be about different aspects of their own education, they're capable of understanding so much. And to your point, when it comes from that internal motivation and they understand the reasons, the effects seem much longer lasting. And we know that in education as well, they're more likely to remember it when they have an interest in learning it and they're excited about it. So I love that you bring the kids into that as well. And I know there's so much more we could cover on this topic, and endless topics within the realm of dental health, but where can people keep learning from you online?
Yeah, so they can find me at www.drstevenlin, drstevenlin.com, or on social medias at Dr. Stephen Lin. Yeah, and so we really try to push the idea forward of functional dentistry and understanding the root causes of dental medicine, instead of just treating the results of that. And so it's something that I think is really powerful for both parents, but also for adults too. There's so much learning that I've done, just going through this. I think you and I are pretty similar in the sense that we always implement things for ourselves before for our children, and it's just such a powerful way for a family to grow and heal together.
Absolutely. And I've always said what we model is more powerful than even what we say. And so when they see us doing it, they're more likely to want to do it as well. I know you have so many resources on your website. I'll make sure that is linked in the show notes, as well as your book. You just are such a wealth of knowledge, and I'm so excited and encouraged to see people like you really on the forefront of this kind of holistic oral care, oral like jaw health, and really looking at these things. So I feel like this was a conversation we ignored for too long, and it's really exciting to see people like you really working to fix it. And a couple last questions I love to ask at the end of interviews. The first being if there is a book or number of books that have really profoundly impacted your life, and if so, what they are and why.
Well, Nutrition and Physical Degeneration was a big one. But we kind of talked about that. So, but actually, Daniel Kahneman, Thinking Fast and Slow, was probably, I look back now, as one of the more influential books in my life, mainly because it was a strategy of thinking and way to look at problems, and not to be kind of tied down by biases. So, one thing about medical problems is that they are so riddled in bias, and being able to kind of think differently behind problems and not just what you were presented with is something that really kind of shaped my thinking, I think, with Daniel Kahneman's Thinking Fast and Slow.
I love it. I will link to those as well. And lastly, any parting advice for the listeners today that could be related to the things we've talked about or unrelated?
Yeah, look, I mean, with parents, it's difficult, raising kids. Everyone knows that the kids are difficult. I would just say that everything, I find that a lot of people that come into the clinic, they're sometimes a little bit overwhelmed with, and sometimes they're a little bit guilty as well that, that they perhaps, didn't know this before, but, that you only know what you know, and everything you do in your child's life is going to have an impact. And, we are all learning in this whole kind of raising kids and, trying to teach our next generation to be better. And, I would try to tell them, not to get yourself down if you've missed something, or if there's something that you feel that, your child has, perhaps been a little bit behind on. But, the positive impact of learning that now is going to have a far more positive experience than, being tied down in the negative of it. So, don't lose hope, and that, ultimately, kids are highly resilient, and they will come through this. And as long as, everyone keeps pushing forward, this is going to be hopefully a problem that we solve.
I think that's a perfect place to wrap up. Thank you so much for your time and for sharing today and for being flexible on scheduling with an ocean in between us. I have learned a lot, as I always do, from you. And you guys, please check out the links in the show notes to keep learning from Dr. Stephen. But thank you so much for being here.
Thanks, Katie. Thanks so much for having me.
And thanks as always to all of you for sharing your most valuable resources, your time, your energy, and your attention with us today. We're both so grateful that you did. And I hope that you will join me again on the next episode of the Wellness Mama podcast.